Thank you so much for having me today. I'm excited to be chatting with you, especially from the Frisco campus, which is it's a beautiful hospital. They asked me today to talk about stress fractures in the spine, particularly for many of you all who are seeing lots of kids. There's no way that you're not going to see a kid who has this, and sometimes it sees you before you see it. So hopefully after this presentation, you'll have a better idea of what to do in these cases. Just really quickly though, since I'm new to the group, I just kind of wanted to chat with you about my background and who I'm at. As they mentioned, well, I'm born and raised in Maryland, which is also another southern state. I don't get much props for that here in Texas, but it is below the Mason-Dixon line. So I hail also from another southern state. I met my wife actually in high school, in our senior year of high school, and we both went on to college at Oakwood University in Huntsville, Alabama. We both majored in biology there, as well as got involved in a lot of overseas missionary work, traveling to Africa multiple times to do a lot of humanitarian work. And then we both went on to medical school at Loma Linda University, which is in Southern California. And we continued a lot of our missionary efforts there. Then after that, I went on to Johns Hopkins University in Baltimore, Maryland, where I did my orthopedic surgery residency training. And this was me with my class here. And what you may notice is that my graduation invited speaker was the Tony Herring right there in the middle there. It was really great hearing him talk. At the time, he spoke about his efforts when it came to amputees and the different prostheses that they used. And for many of the folks at Hopkins, it was their first time hearing him speaking in person. And little did I know that years later I would get to know him even more. But after I graduated from Johns Hopkins in 2016, I went on to subspecialize in pediatric orthopedics at Rady Children's Hospital. For some of you may recognize Peter Newton, who was a Scottish Rite Fellow a couple decades ago also. So I ended up taking my first job actually out of fellowship in Jackson, Mississippi. And it was really an opportunity to help kids in a state where it's pretty underserved. There were only, at the time that I joined, 5 pediatric orthopedic surgeons in the whole state. And by the time my first year was done, there were only 2 of us. And so that made it for a really interesting time. But it was a great opportunity. And while there, I really started to specialize in a lot of different areas within spine deformity. Taking some of the tools that I learned in San Diego, particularly where people love being in the sun and being in the ocean, we were able to kind of perfect putting on waterproof casts for kids who have spine deformities that they get very young. Again, we oftentimes try to not use any hardware in their spine, and so it was great kind of bringing that technique down to Mississippi. And this is one of my cute little patients who I met when she was about 16 months old, and this is her more grown up than that with a nice straight spine. In addition, we did a lot of cases with kids who had neuromuscular scoliosis, as well as just regular idiopathic scoliosis, which a lot of you all are familiar with. It was just an awesome experience treating many of the kids in Mississippi. My kids also grew up also. And this is just a picture of my little ones here. My daughter, she's 10 years old. She's shorter now, but she's taller than my wife now at 10. So she got my genes. And my son, he's 9 years old. So they really were able to kind of grow up and love Mississippi in the South, and will be joining me in Texas soon. So I started about 3 months ago with the focus on spine here at Scottish Rite, and I'm excited just to chat with you all about some of the particulars of stress fractures in the spine. I do have some relationships with industry, with DePuy Synthes and Orthopedics, none of which are relevant to this talk because really we're not really focusing on instrumentation. We're just focusing on identification, diagnosis, and conservative treatment of these stress fractures. So objectives for today, we're going to describe the difference between spondylolysis and spondylolisthesis, which are common stress fractures in the spine. We're going to identify sports and different movements that can exacerbate stress fractures of the spine. And then we're going to also identify key physical exam findings that will help you to diagnose stress fractures of the spine, and then discuss bracing options and other treatment recommendations for kids who may have these stress fractures. So the isthmus is also called the pars, and really it's the connection between the inferior articular facet, as you can see here, and the superior articular facet, which is not pictured. This area actually doesn't get the best blood flow, and so it also becomes a watershed area, which increases the potential risk of fractures. And this is, when you talk about a stress fracture or a pars injury, we're talking about an injury that occurs in this area. Sometimes it just cracks slightly, and other times it'll crack all the way through. And so when we say the word stress fracture, really the true word for it is spondylolysis, and most often occurs at the L5 level and less frequently at the L4 level. Repetitive back extension is like, if you don't get anything else from this talk, if you hear about any kid who does anything with regards to repetitive back extension, this is what most often stresses the pars of the lumbar spine. And so look out for that when you're taking your history. The pars can be fractured either on one side or it can be fractured on both sides. But particularly if it fractures on both sides, you have a higher chance of one vertebra slipping forward in relation to the other. And that becomes a little bit more serious. It's something that might more likely require surgical intervention. But if it breaks and doesn't slip forward, you're less likely going to have to surgically intervene. But if it does slip forward, then instead of just calling it spondylolysis, which is just the same thing as a stress fracture, we call it spondylolisthesis, and listhesis means to slip. So when it comes to why kids get this, we have found out that there is a genetic predisposition with regards to spondylolysis. It actually occurs in about 15 to 70 degrees of first-degree relatives. And when it comes to breakdowns by race, we can see a higher prevalence in whites, but a very high prevalence, about 40% in indigenous Americans, particularly the Inuit tribe. Back in the day, when we were able to do research studies without really any IRB oversight, they were able to do a couple different studies that allowed us to actually figure out what the natural history is of spondylolysis and spondylolisthesis. And we found out that in fetuses, there's a 0%. There's a 0% incidence of spondylolysis. So very few kids are truly born with this. But as they get older, we start to see a higher overall incidence of spondylolysis. And so by the age of 6, they found, after following 500 first graders and basically getting x-rays at different time points, that the incidence of spondylolysis, which again is just a crack at the pars interarticularis, is 4.4%. And this graph from their paper back in this was published in the 1980s, but they started in the 1950s, is that you see incidence of 4.4% at age 6. At age 12, you see an incidence of 5.2%. And as they get older and into adulthood, the incidence is closer to 6%. And so it does get slightly worse as you get older, but it's not like it exponentially increases in its overall prevalence. What they found is that 86% of these pars defects occurred at the L5 level, and about 75% of those were bilateral. And again, when you look into adulthood, you're looking at about a 5.8% incidence overall, and boys have a 2-to-1 ratio of developing this. Now, I would say that data might be a little bit muddied because, especially back in the day, boys might have been a little bit more involved in athletics, maybe due to just socialization. And so there hasn't been updated study, especially now that girls are doing a lot more sports, to see if that ratio has changed. But in general, we're not going to be able to repeat a study like this without doing a lot of consenting. And so this is what we have for now. There's some other studies that have looked at the incidence of spondylolysis in kids. This one was done actually more recently in 2018 in Europe, and they actually looked at the CT scans of kids, about 717 CT scans of kids who got these CT scans for other reasons. Maybe they showed up to the ER with abdominal pain, concern of appendicitis, and they just happened to be able to look at the lumbar spine along with that. And when it came to the incidence, they were able to find that if the kids were less than 3 years old, incidence was about 1%. When they were less than 6 years old, about 3.7%. And total in the whole cohort, the incidence was about 4.7%. So history really matters when it comes to this sort of stress fracture. And so first you want to ask them, where is the overall location of the stress fracture? And of course, if it's non-radiating, that more so makes you focus on the back and less on compression of the nerve roots as they exit the spine. And then really, of course, you want to ask, well, how long has the pain been present and things like that. But the very quick question that I ask is, what sport does your kid play? And very infrequently are they going to say, well, I just do Fortnite. I don't play any sports. Most likely, they're going to tell you some sort of physical activity that they do. If there is a sport where there's a high incidence of repetitive hyperextension of the back, that's where you're going to really want to hone in, and your radar should be going off a little bit that this might be potential stress fracture of the lumbar spine. You can see here that these offensive linemen, sorry, I could only find a video of the Oklahoma football team. I didn't want to offend anyone who might not be a fan of this team. But you can see here as they hit each other on the front line, particularly there's a significant amount of back extension. And after they do this for a couple months or even years, you're going to find that happening. But it's not just football. Particularly kids who participate in gymnastics or cheerleading, especially cheerleading and gymnastics, you're going to find a lot of these injuries. And so if you hear that, oh yeah, well, my daughter is a competitive cheerleader, your radar should be going off a little bit that you could potentially be dealing with a stress fracture of the lower spine. But outside of football and cheerleading, you also want to look at weightlifting, particularly people who do a lot of CrossFit or heavy deadlifts. You want to look at that, as well as divers and swimmers who have to really extend their back to do a lot of their movements. So history certainly matters. There was actually a study published out of Boston Children's where they looked at what the overall incidence was of what the incidence of spondylolysis was of young athletes. And when they looked at 100 young athletes who presented with lower back pain, they found these stress fractures in 47% of them. And so that association with athletics, particularly a sport where they do a lot of extension exercises combined with lower back pain, you really are going to have to hone in on that being a potential cause for their back pain. But what else should be on your differential? You shouldn't just think about potential stress fractures of the lumbar spine. Other things that can cause back pain are just nonspecific. And really, as someone who sees a lot of kids with scoliosis, this nonspecific back pain is probably what I see the most. And when we say nonspecific, we're probably talking about muscle dysfunction, hamstring tightness, things like that. But there are other causes of lower back pain, including disc herniations. We talked about spondylolysis and spondylolisthesis, but you can't rule out tumors. There are a lot of benign tumors that actually like to sit in the back of the spine that can cause pain, as well as potential infection like osteomyelitis. So all of those should be on your differential. So when it comes to your physical exam, there are a couple things that I do. First, I always touch their back. You want to see just where is their pain truly, and then I have them touch their toes. And this allows you to evaluate if there's any asymmetry of the spine to look for scoliosis. But then as they come up, the next thing I have them do is lean back towards me, extend their back. And if they say, look, doc, I can barely extend my back, or my back really hurts when I extend, you got to really be concerned about spondylolysis. And then you just check their overall exam. This is something that anyone can do in clinic. Have them walk on their toes, have them walk on their heels, see if they can walk in a straight line, almost like they're walking on a rope. This overall checks their posterior fossa, their brain, their cerebellum, to make sure there's no coordination issues, as well as it makes sure they haven't been drinking alcohol that day. And then you have them hop up, that was a joke. Then you have them hop up and down on one leg. This overall checks their strength. Then you want to check their patellar reflexes as well as their Achilles reflexes, as you see me doing here. And again, these are all things. You do not have to be an orthopedic surgeon to do this exam. Particularly, I feel that there are a lot of pediatricians listening to this. So these are all things that you can do before you refer them to see us, just to make sure there's anything's going on. This is me just checking for clonus on both sides here. And then you can also do the Babinski test. This is important also, having the patient do a straight leg raise. Make sure that if there's any shooting pains going down the leg, particularly posteriorly, then you might be dealing with potential disc herniation, which could be a potential source of their back pain. And then I flex their hip up to 90 and extend their knee to check how tight their hamstrings are. And these are all things you can do to try to localize the source of the pain. Most people, you should be able to get their knee completely straight. If it's much less straight than that, then you might be dealing with significant hamstring tightness. And if anyone checks themselves, I think a lot of us have really tight hamstrings overall. So when it comes to imaging, like I said, particularly if you've done your physical exam, they have pain with back extension. They have pain when you palpate their lower spine. You really need to have a high level of suspicion that they might have a stress fracture in their lumbar spine. But the next step is getting an x-ray. For orthopedic surgeons, they're going to always be getting some type of x-ray. But for you all who are in primate care clinics, or even like athletic trainers or athletic trainers working with orthopedic surgeons, you can still go ahead and order the x-ray. And if you're not looking at it, the thing that you want to make sure is that this x-ray is a standing x-ray of the lower spine. And so that's what you want to kind of make sure that they're not lying flat. And so get a standing x-ray of the lateral spine. But there is some discussion about what sort of imaging is actually needed. There was a good study actually that came out of CHOP where they looked at 2,800 kids who presented with back pain. I think one of the most interesting things from this study is, if you can see here from this black line right here, is that the majority of kids out of that 28 who presented with back pain had what we call this non-specific lower back pain. This is the thing where you get x-rays, you touch their back, and it just hurts. We don't really know why it hurts, but it just hurts. And what's interesting, though, is that for those kids who had purely mechanical back pain, when you look at the number of clinic visits it took to resolve it, it really was close to about 2 or 3. And so, and for most of them, it was actually less than 2. So these are not patients that we are often having to see multiple times back, particularly when we treat them conservatively, which we'll talk about a little bit later. So 76% of these 2,800 kids had no underlying etiology for their back pain. So don't necessarily suspect that all lower back pain is going to be due to spondylolysis. And 61% had less than 2 follow-up visits. But if you are dealing with spondylolysis, which is that stress fracture of the spine, this is that less black line here, you'll see that the number of clinic visits actually increased significantly. So we are having to see these kids a lot more often in order to treat them. So when it comes to what we're looking for on imaging, some of you all may remember from medical school or from PA school that we're looking at the Scotty dog. And I'm not really a dog person, but I just brought this up so that you all could see it. But when you draw an outline of the overall lumbar spine from the side, it actually looks like a Scotty dog, as you can see here in this picture. And where the pars injury occurs is actually at the neck of the Scotty dog. And so that is what the pars looks like when you're looking at a lateral x-ray. So you've got these x-rays, and many times I will say the majority of the time, you actually can't see this injury on x-ray at all. And so a lot of your treatment is being based off of your overall clinical exam and just your suspicion that something is likely, going on here. And again, very quickly before it popped up, this is that Scotty dog and where the pars injury actually occurs right there. Some people will say, well, what should I do next? If I suspect that my patient has a spondylolysis or a stress fracture at the pars, should I go ahead and get an MRI or should I get a CT scan? And I would say, really, personally, you should stop right there and say, if you don't see it on x-ray, the first line treatment is conservative. And so if the MRI or the CT scan is not going to guide your treatment, there's no need to incur the expense to our healthcare system to order that. And there actually has been some good data to really look at the comparisons. This study actually came out of the Children's Hospital of LA, and they looked at kids who had actually been confirmed to have spondylolysis by getting a CT scan, but who happened to also have gotten an MRI. And in their subjects, they actually found that in 64% of the kids, the MRI read actually missed the spondylolysis. And so you get the benefit of not exposing the kid to ionizing radiation by getting the MRI, but you actually miss the diagnosis. And so in general, I'm not getting an MRI on most of these kids. And I'm really not getting a CT scan. If based on their history and physical, I think that they have it, I just treat them conservatively, which we'll talk about a little bit later. But if you are in clinic and you're thinking about referring them to orthopedics, I would say don't order an MRI, don't order a CT scan. At the very least, get an x-ray. And then if your clinical suspicion is high, then just refer them in so that we're not either exposing the kids to ionizing radiation or wasting healthcare resources by ordering an expensive MRI. Somewhat in defense of the MRI, you can increase the diagnostic sensitivity of an MRI by changing your protocol to actually get in line with the fracture line to better identify the fracture line at the pars. You actually have to utilize radiology and get them to actually take an MRI slice that is basically truly parallel with the fracture line. And so this was a study that was actually done out of Switzerland, where they actually did a meta-analysis of all the papers that actually looked at the sensitivity and specificity of MRIs for identifying spondylolysis. And what they found is that in general, the sensitivity was not horrible, it was 81%, and the specificity was 99%. But particularly they mentioned, as you can see down there, that you have to use a thin slice type of cut through the MRI in order to find it on MRI. And I think a lot of people, not everyone may have the MRI capabilities to actually do this. And so in general, you should probably just leave the MRI for the experts and just let us order it. I know there's some people who might own their MRI and so might potentially get some revenue from ordering it on your own. But so if you're going to order MRI for whatever reason, at least make sure that it's thin sliced so they can better identify it. But truly getting an MRI or CT scan is not guiding our treatment at this point. So here is just an overall literature-based proposed algorithm for what to do from an imaging standpoint if you're concerned that the child does have spondylolysis. And again, just know that there is tremendous inconsistency and variability when it comes to the literature on this front. So at the very least, if you're concerned that a kid might have spondylolysis, get 2 views of the lower spine. That's an AP and a lateral view. Make sure that the kid is standing. There's no need to get additional oblique views of the spine. There's not been any data to show that that's helpful. And as I mentioned, advanced imaging is only going to be used if it's going to affect treatment or if the x-rays are non-diagnostic and you're really concerned that something might be going on here. As we talked about, CT and MRI might have comparable sensitivity if you get the right slice on CT scan. But MRI is actually pretty useful if there might be a stress fracture that actually hasn't cracked all the way through. The MRI will actually show edema at that site. But again, is that going to change your treatment? Because you're still going to basically take the kids out of sports, treat with scheduled anti-inflammatories, and do physical therapy. But if you really want to know, you're dealing with the family who just has to have some idea of what's going on, the MRI can detect early stress fractures before it actually cracks all the way through. There actually was another natural history study where they looked at 500 first grade children to see what happens if you do nothing to these. And interestingly, as they followed these kids for almost 45 years into adulthood, they found that if you had a crack of your pars only on one side, that it never turned into spondylolisthesis, meaning that there was never a slip forward of one vertebra on the other. And so that's a good sign in general. They found that women who had pars defects that were discovered when they were little girls, that even those with bilateral pars defects, they didn't have any increased back pain whenever they had kids. And so that was a good sign also. And when they looked at patient-reported outcomes, particularly the SF-36 scores, they noticed that overall pain did increase as they went into each decade. But overall, this actually tracked pretty much with what happened in the general population. As we get older, we tend to get more back pain. And so it didn't seem like there was a significantly higher incidence of patient-reported outcome scores with regards to pain as they follow these kids over time. And again, interestingly, none of these patients ever filed for disability. And so parents are asking, well, what might the future look for my kids? Is the future bleak? Well, we can say that probably they're going to have back pain at around the same rate as just the general population in America. So treatment, I know we talked about this multiple times, but in general, when I talk to patients about treatment, we're talking about like a trifecta here. And there is no gold standard treatment. I think a lot of people do different things. But in general, if a kid is involved in a sport where they do a lot of back extension, football, cheerleading, gymnastics, really we've seen in some other sports too, like volleyball, basketball, and things like that, we tell them for 3 months, we're shutting it down. And I used to be an athlete, and that's like a death sentence to them. They're like, what? I mean, like I was supposed to go to the NFL or go play for the Olympics. They all think, that that's happening. But you really like have to shut it down for 3 months because there's an inflammatory cycle that's going on in their lower back that you have to stop. And so my general spiel is for 3 months, we're shutting it down, no sports. And then we also want to pair that with physical therapy during those 3 months. And really, I don't tell the physical therapist what to do. Most physical therapists now have their doctorate. And so really, I just say treat per protocol. And truly what I found that a lot of therapists are doing is they're working on the core of the patients, their abdominal muscles, their paraspinal muscles, working on their hamstrings. Just let them do what they know to do for folks who have basically a weak core and tight hamstrings. And then I always pair that with anti-inflammatories. I think there's some people who just say, oh, just take something over the counter. But I truly feel, and this just may be my bias, that if you prescribe something, patients feel like they actually got something out of the deal here. And so I say for the first month, I want you taking these NSAIDs every day, whether you hurt or not, just to knock this inflammatory cascade out. And then for the second 2 months, I had them take it only as needed. But again, everything is happening for 3 months. We're really going to hit it hard for 3 months. When it comes to the type of anti-inflammatory, it's your pick. If you're dealing with a very young kid who only takes liquid, I try to do liquid naproxen, which was actually pretty cheap in Mississippi, but I'm finding here in Texas for some reason it's very expensive. If they're older, I like to use meloxicam or Mobic just because it's a one pill, so they're not having to take a lot of things, but it can be your choice. But either way, during those 3 months, we want them taking anti-inflammatories. So we're shutting them down for 3 months when it comes to their sports activities. We're having to do physical therapy for 3 months, and we're putting them on anti-inflammatories for 3 months. Invariably, the parent will look at me, the kid will look at me, the kid will look at the parent, and they'll say, can we just do one of those? And usually they don't want to stop sports, but they'll do the therapy and the anti-inflammatories. And I tell them, yeah, certainly we can do that, but just know that your recovery may take 6 to 9 months instead of 3 months. And as long as you're okay with that, then I'm okay with that. But if you were my kid, I want you to shut it down for 3 months. And most people tend to understand that. I don't think there's ever been a study to actually look at what the compliance is actually of doing that. That'll be something interesting for us to do in the future here at Scottish Rite. But when it comes to treatment, when I say conservative treatment, this is that trifecta that we're talking about there. And so why the physical therapy? And as I mentioned, the core is very important. I actually don't care, and data has shown that it doesn't matter if that fracture never heals on x-ray. What we care about is taking care of the symptoms. And as long as the symptoms go away, then we're happy. And so a lot of times the physical therapists, they're working on building the core. But the question is, why does the core matter? And really, the core almost acts as supporting the lumbar spine. We know we're not healing the fracture because we're not operating on it. But in particular, if you strengthen the abdominal muscles and the paraspinal muscles, that provides more stability to that lumbar spine and actually helps these kids get better. There's an interesting study out of Switzerland again, where they looked at the association of back pain and the overall physical fitness of kids. They looked at over 9,400 kids at the age of 17. And what they found is, based on how kids did with this test, and it's some Swedish name that I can't pronounce, but this test where basically they have to hold a plank at the end of this bed, and they test how long can the kid hold their back perfectly straight in this position. They were able to find a direct correlation between how long kids could hold their back in this position and the development of back pain by the age of 17. And so again, if their core was stronger, their overall incidence of development of lower back pain was actually much lower. And so this is why we send them to physical therapy, so they can get that training in their overall core. And again, maybe one of my biases also is that I almost never tell kids, here's a paper, just do these home exercises. We'll see if that back pain goes away. Because I know I'm a horrible patient myself. If someone gives me a sheet of paper, says to do it, I'm going to be doing everything else but those exercises. I feel, though, that if you prescribe physical therapy, send them to an actual facility, people are going to have a much higher chance of actually doing the exercises and getting the benefit of it. But again, the core does matter when it comes to overall back pain. Some people have asked, well, what about bracing? Is there any data that shows that bracing actually helps? And this is actually controversial in the literature also. There is very little data to support bracing, but there are a lot of people anecdotally who swear by it. And I will say I'm probably somewhere in the middle. But when you look at the data, there was a study, a multi-center study done by multiple pediatric hospitals across the country, where they looked at the overall natural history of spondylolysis in kids. And one of the main, there's supposed to be another slide there. Yeah, so what they looked at is about 89% of these kids were braced initially, and about 84% of these kids received physical therapy. And after about 5.5 months, they found that radiographically, 24% of these kids actually healed their stretch fractures radiographically, and 46% had incomplete healing. So again, radiographic healing is not something that we're worrying about. It's more so about their symptoms. But I think more importantly, bracing had no effect on their overall return to activities. And so that's one knock against bracing. There's another study where they actually looked at how did bracing actually affect the healing of these stress fractures if you got a CT scan of their spine. And what they found is that actually if you brace the kids sooner, they're more likely to be less symptomatic and have improved healing on CT scan. But there are lots of other studies that have also disproved this. But this is one potential feather in the hat for folks who do like to brace these kids. There was another study where they actually did a meta-analysis looking at 15 different studies, seeing what the overall outcome was of non-operative treatment. And what they found is that if you treat these kids with these stress fractures of the lower spine, non-operative treatment has nearly an 84% chance of success in over 665 kids. And so again, conservative non-operative treatment is the mainline treatment for kids with stress fractures of the lumbar spine. And this has been proven multiple times. But something else in this study, they found no difference in the success rate based on use of a brace, okay? And so this is, again, one other knock against the use of a brace. I think this is that same study, yeah. And so further on in that study, they actually found that when it came to the overall acuity, if someone showed up with an acute pars fracture, let's say they were deadlifting in clinic or they were deadlifting at school, kind of pulled up and they felt an immediate pop in their lower back and had pain, came to your clinic and it showed a pars defect, those had a much higher chance of healing because, again, we're dealing with an acute fracture versus if it's just some more vague, progressive back pain, more of a chronic spondylolysis, the overall healing rates were a little bit lower than that. And again, radiographic outcome in this study was not correlated with clinical outcome. Always treat conservatively. Let's say that you do the bracing plus or minus, do the physical therapy, do the activity modification, taking them out of sports, treating with NSAIDs. It's been 3 months. They made slight improvement, maybe not as much as you want. You go another 3 months to see if it'll get better, and they're really not happy. Their quality of life is still being affected. The next line treatment is not surgery. We next try to see if can we directly decrease the inflammation that's at the pars. And so I send them to interventional radiology and have them actually do an injection of the pars under light sedation. And a lot of them might get injected every 6 months. And if that decreases their symptoms, you're golden. Because again, surgery should be the absolute last option. And so I would say there's probably less than 5% of kids that I've ever had to refer for this. And if you're not in orthopedic surgery, you're going to be less likely to make this referral. It's likely to be the orthopedic surgeon that makes this decision. But just know that if you're referring them, we're doing a lot of things to prevent that kid from ever getting to the OR. And injections of the pars is kind of that next line in treatment if it fails. But if injection fails and the patient comes back multiple times, I try to talk them out of surgery and they just want something done. Then we do have surgical options to actually treat them. And we're not going to really focus on this, but there are kind of two different ways you can treat pars defects. One is a direct pars interarticularis repair, where basically you have a crack at the pars. Again, the pars is actually angled nearly 60 degrees downward. And what we do is we just take a screw and we basically shoot it across there and try to compress that fracture. And actually that doesn't take away really any motion at all because we're not fusing the spine. It's almost like directly repairing a fracture. But you can only do a direct pars repair if the gap is not too wide, because it is really hard to compress that area. But that is an option. And what more likely happens, because most of these pars defects, they're going on for months to a year, they're too chronic and the gap is too wide to actually directly repair, is that we have to do a fusion. And we have to actually, meaning we go in, we scrape out the area that won't heal, and then we basically, with rods and screws, just compress that entire area. Fusion does decrease some of your motion. And in general, a lot of these kids still have some pain afterwards. It's a different type of pain, but they're not really 100% happy and being the high-level athlete that they used to be, although there are many kids who do return back to sports. So just know that surgery is an absolute last resort when it comes to the treatment of these stress fractures. Thank you all for your time. Hopefully this allowed us to better understand how both to identify pars fractures of the spine or stress fractures of the spine, what the difference is between spondylolysis and spondylolisthesis, what sort of imaging to actually get, and what are all the conservative methods to actually treat this, and how useful brace is. And so I'll take any questions for anyone that has any, both remotely or here in the room today.
Dr. Brooks, that was an amazing talk. Really hit on almost everything that we wanted to know about in terms of the evaluation of this condition and really globally back pain in our youth. I wonder if you could summarize maybe in 3 bullet points whether a pediatrician, athletic trainer, or pediatrician or physical therapist. What are 3 bullet points that should raise our suspicion that we should perhaps refer or consider imaging when a youth athlete presents with back pain?
So, you don't want to be getting x-rays on every kid because that is ionizing radiation. And so you want to decrease as much as possible. But if it's acute, they heard a pop and they have acute lower back pain, I think that's grounds to get a standing x-ray of the lumbar spine. If they tell you that they were playing some sort of sport where there's a lot of back hyperextension, cheerleading, gymnastics, football, swimming, and they have lower back pain, that would be something to raise your suspicion. And in addition, if they've actually tried, like their back is hurt for 3 months, they actually stop playing sports on their own and their back still hurts, they've already tried to modify their activity. And if that didn't work, then you got to be concerned that something else is going on. And so pain that hasn't gone away, even if they decrease sports, they're involved in back extension sports or exercises, or there's an acute pop with pain, that will at least want me to get an x-ray. And then from there, you just refer them in. We actually did a study a couple years ago where we looked at what were the things that pediatricians, pediatric orthopedic surgeons, pediatric radiologies were sued for the most when it came to musculoskeletal issues in kids. And actually, this was not one of them. They got sued more often for missing scoliosis. They got sued more often for missing kids who were born with dislocated hips. They got sued more often for missing tumors in the bone. But this is not one of them. So you don't really have to stress out to say, what if I miss this? Because a lot of times we don't see this on x-ray, even if we get the x-ray. So we're treating them clinically, even if we're not necessarily seeing it radiographically.
I would certainly welcome any questions from the audience as well, but while they're thinking, we've got 2 questions online. One of them is, do you use a SPECT scan to determine acute versus a chronic condition in the back?
So absolutely not. The SPECT scan was something that we used to do all the time. but the amount of radiation exposure to the kids is astronomical. And so we and really it is not much better than just a regular CT scan. And so that has fallen out of favor, and there is no more evidence to use SPECT scans anymore. And so if you have to choose an imaging of, if you wanted to choose one imaging study to basically find out if the kid truly has a pars fracture, I would choose a CT scan at a low dose protocol and then just send them in. But if you have to choose really one thing to get, just get a plain x-ray and then just refer them in, because most times it's not going to affect how we treat the patient. The only times I'm really getting a CT scan is if I'm trying to see that area before I operate on them, which again happens so infrequently that I get very few CT scans. All the CT scans I get are from people who've ordered them from outside and then referred the patients in.
Now, staying on that concept, when thinking about an acute versus a chronic scenario, will you treat them differently if you think it's there's some acuity to it?
Yeah, that's a good question. So usually the kids who felt a pop, they hurt actually way more. Like their pain is like 9 out of 10 versus the ones who they just kind of had this vague back pain for the past couple months. And so when they kind of walk in like stooped over and kind of bending forward because they're having so much pain when they extend their back, I'm going to be more likely to put them in a brace. So I'm still shutting down their sports. I'm still treating them with anti-inflammatories and doing physical therapy, but I'm more likely adding a brace onto those kids with acute injuries. Again, with no clear data to support it, just anecdotally, that seems to be what works better.
Yeah, I mean, it sounds like a brace both in the acute setting and also for those that are having significant pain as a symptomatic form of to treat their symptoms of their back pain. What about what if you feel as if it's incidentally found on MRI, some edema within the pars interarticularis or a spondylolisthesis that perhaps isn't associated with back pain? How do you treat or address that?
Absolutely. So again, that's the problem with the MRI. It's so sensitive; it picks up things that don't hurt. And I think there's a study in adults that especially once you get over the age of 60, MRIs pick up a lot of things in the spine that don't hurt, disc herniations that don't hurt, all sorts of things. And so the same way, if the kid is asymptomatic, we do nothing. There's no need to chase after that all because you incidentally found a potential increased edema in the pars on MRI. If you ask the kid, "Are you having any pain? Is anything stopping you from doing your sports?" and they said no, we leave it alone. And I tell the parents, if that changes, come back. You're going to know much better if there's a change in their overall activity. I'm not going to just keep on bringing you back to clinic for no reason. You're going to know if there's an acute change in what they can do. And so, but truly, if it's incidental and they're asymptomatic, you leave it alone.
What about a listhesis, a shift? Does that change?
That's very different. And so if there's a defect on both sides of the pars and there's a slip forward of one vertebra on the other, those patients we follow very closely because the data does show that as they get older, there is an increased incidence of them slipping further and further forward. And if they slip more than 50%, those kids are more likely going to also have kind of compression of their nerve roots that control hip flexion and things like that, and more likely need surgery. And so spondylolisthesis, which is a slip forward of one vertebra on the other, is something that we follow very closely, get multiple x-rays on, and have a higher rate of operating on versus just a break with no slippage.
Great.
Hi, great talk. I had a quick question. If you have a patient who doesn't want to follow the activity restrictions, they do the two other of the trifecta, does that maybe increase any of their risk if they continue participating in sport for lower extremity injuries? And what does that conversation look like?
So there's been no data to support whether it increases the rate of lower extremity injuries. I would just say it increases likely the rate of just back pain that won't go away. But I think a lot of, especially the folks that work here in Frisco, we all used to do some sort of sports. I think we all kind of played through some injuries because we didn't want to stay out of the game. So we shouldn't demonize the kids for wanting to stay playing sports. And I don't think there's been any data to show that they're going to be permanently disabled because they decided to keep on playing. Really what I counsel the families is this is just going to make this injury take a lot longer to get better. And so if they're not willing to do the trifecta, I kind of ask them, when would you want to start? Because usually it correlates with some sort of end of a season. And so I try to really kind of figure out, okay, you play baseball, soccer, basketball, and football. When is there a gap between any one of those sports so we can really start this? And getting them thinking along those routes of, okay, when can I fit this in within my schedule, sometimes actually increases compliance. But if they're not willing to do all three, then I will more likely probably just send them home with some Voltaren cream and say, when you hurt, just rub this on your back and come back when you're ready to do the real deal.
In trying to consider non-operative management, which clearly this is a condition in which majority is treated that way, do you ever get worried or have some considerations about long-term NSAID use, or has that been, if you put them on meloxicam or naproxen for a month or 60 days, is there a time in which you're concerned about that long-term?
Absolutely. And so really we're only talking about 3 months, but interestingly, some kids have such sensitive GI tracts that there've been, I could say probably a handful of patients who have called me like a month later, said that they did the therapy, they stopped playing sports, but they had to stop taking the NSAIDs because they just were having too much stomach pain and things like that. And so that does happen, I would say less frequently than you think. And particularly, we're not putting them chronically on it. We're really talking about a 3-month trial and then we're done. So I would say that the benefits do outweigh the risks. But certainly if there's a patient who has a weak GI tract or has a history of a kidney transplant and can't be on any NSAIDs or things like that, then I'm more likely then to offer them the topical cream, the Voltaren cream, so that there's not a systemic ingestion of NSAIDs as kind of like a backup.
And I think that's yeah. I mean, the topical anti-inflammatories have really been great for kids because it doesn't affect the rest of their body as much as some of the orals. So I find that to be really useful in so many other conditions. Not unlike other stress fractures or stress reactions that we treat. What kind of considerations do you have with the family regarding sleep, nutrition, vitamin D, and then lastly, is there an indication to use a bone stimulator in these patients?
Yeah, no data to support any of that, but I'm sure it's being done. In fact, a lot of the patients that come to me, they've already gone to the chiropractor. Less have done acupuncture. A lot of them have been using their parents' heating pad or things like that. And so there's been no data to say that it hurts them, but there's been no data to say that it helps either. There have been studies that have tried to get at the correlation between low vitamin D levels and back pain. And there are some that even think having low vitamin D levels might increase the incidence of scoliosis. I will say that it can never hurt to take vitamin D. A lot of us are vitamin D deficient, and so just go ahead and supplement your kid. But there's been no data to say that that's going to replace physical therapy with building your core, taking anti-inflammatories, and stopping the sports. But it can certainly be a fourth thing that you add on to that trifecta, which is supplementing with vitamin D, out of all the things that you mentioned.
Yeah, like you said, I mean, I think sometimes we get so anxious to want to do everything for our child to get them back as quick as possible. But the reality is it's probably rest and mechanics is probably the most important of them all. So, well, unless we don't have any questions, Dr. Brooks, I want to thank you for a great talk.
Thank you for having me.
Taught me a lot. I think it taught a lot of people. I think it's very engaging, interesting, and really look forward to hearing more from you. And thanks again, and we appreciate it. And for those that are listening online or that are watching this in a delayed fashion, next month we're gonna focus a little change body parts. We're gonna focus a little bit more on the pediatric foot exam, in which we're gonna have a combined talk on the examination of a foot in a pediatric patient, as well as we're gonna have our orthotist give us a talk on different orthotics to use for different foot conditions in our youth. So stay tuned. It'll be a 2-part series next time. It'll be a month from now in December. So stay tuned for media on that. Thanks again, Dr. Brooks. Appreciate it.
Awesome. Thank you for having me.